You're listening to the Peer-to-Peer Academy podcast. I'm your host, Dr. Nick Bruns. During each episode, we'll draw back the curtain on in-depth medical conversations directly from your peers, the kind that you won't hear in the clinic or at the podium. It's ophthalmology and optometry unplugged. Let's go get it. Thanks to our sponsors, RxSight, Star Surgical, and Lensar. Because of their support, we're able to bring educational content and discussions like this to you. In this episode, I have an amazing conversation with a talented group of doctors, Dr. Vance Thompson, Dr. John Vukich, and Dr. Rick Van De Velde. Not only do they each excel in their respective fields, ophthalmology and optometry, but they also have extensive experience working in teams to give their patients the best eye care possible. You'll hear about each of their approaches to creating efficient MD-OD collaborative care relationships and how their models have resulted in incredible outcomes for patients. If you've ever had questions about collaborative care, this episode has the answers and more. Before we dive in, make sure to subscribe to Peer-to-Peer Academy wherever you listen to podcasts. Now let's turn it over to my conversation with Dr. Thompson, Dr. Vukich, and Dr. Van De Velde as they share their insights on what it takes to turn a dream team into reality. Let's go get it. Hey everyone, welcome to episode 2 of Peer-to-Peer Academy podcast. I'm Nick Bruns. I'm joined by 3 awesome guests tonight. So first I've got my clinic partner, John Vukich. John is the founder of Summit Eye Care. He's a specialist in refractive cataract surgery with over 30 years experience and extensive experience in clinical research and innovation. We've got Dr. Rick Van De Velde. Dr. Van De Velde is an optometrist like myself down in Georgia. He's the director of clinics at Southeast Eye Care, specializing in ocular disease and pre- and post-operative care, and mainly glaucoma and cataract refractive. And then Vance Thompson. Vance is a legend in ophthalmology, founder of Vance Thompson Vision, specialist in laser vision correction, advanced cataract surgery, having performed over 100,000 vision correction surgeries. So, guys, thank you all so much for joining us tonight. This is going to be an awesome chat.
Happy to be here. Thank you for having me.
Thanks,
so
Nick.
What I want to talk about, I think eye care in general is, it is evolved. And my career is only 10 years. I've only been doing this for about a decade. But even in that 10 years, it has evolved so much. And we want to talk about tonight kind of how optometry and ophthalmology work together, the advantages to that, why this seems to work. So Vance, why don't we start with you? I mean, Vance Thompson Vision, that's kind of a staple in ophthalmology. It's grown so much. Tell us about how you started that. And I know your practice is, optometry is heavily involved. So tell us a little bit of how that started and how you use optometry in your clinical environment.
Sure. Well, first of all, I just did everything that John Vukich told me to do. So, and that worked good. And, but we actually do share very similar philosophies and, professional journeys in refractive and cataract surgery. And when I came back to my home state of South Dakota after my fellowship in refractive surgery, I found that, like John, loving clinical trials and, heavily involved in clinical and surgical refractive surgery, it was getting overwhelming to me. And I had worked with an optometrist who was practicing in small town Minnesota, and he had done a residency with Steve Slade and Rick Baker in Houston. So he knew the refractive surgery language very well. And I could tell I was dealing with someone special in Doug Wallen. And I asked Doug to join me because I was really getting overwhelmed, to tell you the truth. And so that's one of the first things about, optometry and ophthalmology working together is, we were just able to do a lot more together with his emphasis on clinic and my emphasis on surgery. And of course, talking about cases and doing things together. And then it just continued to grow, that model where, we, asked another optometrist, Dr. Keith Rasmussen, who had also done a residency in refractive and cataract surgery and ended up being, super important. And so I've worked with one of them for over 30 years and the other optometrist for over 20 years. And so we we really are like-minded. And in our practice, that now I have all these, other rock star ophthalmologists and optometrists that I work with. We have found in our model, we're optimized for what we do with one MD, two ODs per what we call galley, rocking and rolling in clinic and surgery. And so this collaborative care model between ophthalmology and optometry has been foundational at Vance Thompson Vision.
Yeah, I feel like it's an efficiency thing for sure. I mean, to have several people working on, because as many patients as we see, it keeps the clinic flow. But I also find, and John, you and I think can attest to this, just two minds are better than one. You got two different opinions, two different sets of experiences that can sort of shape a surgical outcome. And these surgeries that we perform, that you guys perform, are complicated. And we're measuring down to the micron. And so to have separate sets of eyes, I think, with different levels of experience and different experiences individually, that kind of helps. Rick, what about you? Why don't we jump to you? I mean, as an optometrist, you started your career back in the 80s, and optometry has changed in itself a ton.
Yeah.
You came out of school.
I was one of those that started, much like Dr. Thompson talked about, early on in refractive cataract surgery. Came out of school back when optometrists were just, depending on the state, just barely able to be involved in anything in a therapeutic realm, barely just starting dilating eyes legally in Michigan at that point. Drifted into fortunately, an ophthalmology practice. They already had two ophthalmologists, one optometrist, and they were looking to add to that. At that point, it was really more primary care optometry with some post-op management, some pre-op evaluation for cataract surgeries. And then as scope of practice evolves, as need evolved, as skills improved, the two optometrists took on more and more responsibilities, preoperatively, postoperatively, treating eye disease, superficial things initially, and then more and more involved as we went, through our careers. 15 years later, opportunity to go to South Georgia, away from the snow, to an opportunity where I could be more of a leader in the clinic. I could be a clinical director, a practice that was becoming more involved with multi-specialty in ophthalmology. And really from that point forward, dove into strictly disease, no primary care at all, preoperative care, postoperative care, disease management, lots of glaucoma care. If you want to get a lot of experience with glaucoma and diabetic eye disease, come to South Georgia. It's just rampant here still. But still, for the large emphasis of my career, it's been refractive cataract surgery and refractive surgery. And I've watched optometry just change in my career and watched that we are becoming far more capable of being involved in the medical and the surgical arena in eye care. And I think it's needed. I think the future holds a need for that. But, at present, I think there's just a huge opportunity for the two professions to continue to work together and evolve this sort of practice model. Whether it's a surgical group using optometrists as primary care to feed itself, or more of a specialty referral eye care center that the optometrists as well as the ophthalmologists are strictly doing more secondary and tertiary level of care, which is just kind of what I enjoy doing. But those are kind of a couple of models I see out there.
You must have learned a lot on the job. I mean, especially back when you graduated in the 80s.
There's no question. I was not, in the early 80s, there were residencies for optometry were few and far between. I just started, first I had to figure out what plus cylinder was. I was used to minus cylinder, and then we went from there. And then a lot of training, benefit of having a couple of very kind ophthalmologists that were willing to let me come under their wing and peek into the microscope and observe in surgery and listening a lot. Surprising what you can learn if you listen to somebody who's more experienced and skilled than you.
I think this collaborative model only works if it's a two-way street. You got to have an OD who's willing to learn the hard way a little bit, and you got to have an MD on the other side willing to teach and be patient.
Mm-hmm.
That's how I started. I mean, I started in glaucoma heavy too, and optometry school does a fantastic job, but there are definitely deficiencies, especially in the surgical side of things. There was things that I was learning way on the fly because I'd never been exposed to it, and you have to have that environment that is able to harbor that
supportive
need and support. Yeah, exactly. John, what about you? What's your experience with optometry? I mean, now you've got it lucky because you got the most rock star OD that there ever was.
Well, who'd you hire?
Yeah. That would be you, Nick. That would be you. So I've been involved with working collaboratively with optometry virtually my entire career. I have been for many, many years involved and on faculty at two different schools of optometry. We have optometric students who come through our clinic. We have had a fellowship for over 15 years. I was director of a fellowship for the Illinois College of Optometry. And through all of that experience and exposure, it has been enriching to me personally, and I hope to those who have come through to train with me as well. But what it's really done is it's underscored the opportunity of collaboration and how there is synergy that is involved. Nick, you touched on the fact that, we get together and we talk about patients all the time. And there'll be things where I'll see something on the topography, or you'll have a question about, what is the right way to go when there may be two or three options. And I find that not only does it make us better as a clinic, it provides insight from points of view coming from different directions. And I think that just enhances patient care. So I see the MD-OD relationship not only continuing to evolve, but it will strengthen as we go forward. Historically, there has been some sense of competition that, quite frankly, I just don't know that it makes much sense. I don't think it's real. But our respective academies have not always understood or embraced the possibility that there is strength in collaboration rather than competition. And I think that we're on the forefront of understanding that that is not the case. And so when I look at our collaboration, Nick, it is something that I think makes us better and stronger as a clinic. It provides better care for our patients. And so given that there's a wide diversity of practice patterns within optometry, there are individuals who are very comfortable within a corporate setting where there is more of a retail bend. And then on the other end, there are individuals like yourself and with Rick to say, all right, we're going to be more involved in the medical management of patients. And I think that provides rich opportunity for optometry as well, because there is the opportunity to follow your passion and your interests. And I see that as a continuing to evolve pattern that I not only encourage, but I think strengthens our professions.
Yeah, totally. I think there used to be more of a headbutt. And in my personal experience, I think I've been blessed that I haven't been exposed to that. I've been surrounded by ophthalmologists who just really embrace this collaborative idea. Now, I think we are trending definitely more towards this collaborative model on a more national scale. Let me ask the surgeons on the call here, is there certain technologies, or is there maybe a reason that we're trending that way? Or are there certain technologies? Ophthalmology is just, it's moving so fast. There's new things every single month, it seems like. Is there certain technologies that are really kind of highlighting the need for the collaborative model? Vance, what do you think? We'll start with you.
So I think there's, both needs and technologies. We just have this growing population in our world that the amount of doctors is, having a hard time keeping up with. And so this idea of collaboration to take care of our growing population needs, I think, is really important. And that will just continue to grow. And but there's also some neat technologies that really lend themselves to the collaborative care model. And in our practice, we've had really good luck with, the light adjustable lens and so a technology that we've been involved with since its beginning, and it is a technology that, especially early on, is more labor intensive. And so, me focusing on the surgery and the optometrist focusing on the light adjustments, it really has worked really well. And that would be an example of a technology that we worked really complementary together.
What do you think, John?
So I think Vance brings up just an incredibly good example. I think like maybe in general, what we do now in eye care, everything is a refractive procedure. Patients don't come in saying you're the doctor, do whatever you want. Virtually everyone comes in with a specific, I'd like to be able to read a little better. I want to have distance vision that doesn't require glasses. So we're a refractive specialty, whether we like it or not. We have expectations that we have to meet. The light adjustable lens, I think, is the prime example where we can do the surgery, to everything goes absolutely perfectly well. But that final tweak, the final adjustment involves understanding and listening to the patient, getting an accurate refraction, and then doing that treatment. And so, Nick, we've developed just this great relationship that, I'll take care of the surgical part, but the patients really rely on you for the end result. And quite frankly, I rely on you to have the excellent results that we get. And I'll share just a brief anecdote. We were ready where you had done the two adjustments and the patient had already one lock-in and they were ready for their last lock-in. And you had a talk or something you were giving. You were out of the clinic that day for a time away. And they had me scheduled to do the lock-in, and the patient canceled. They said, "No, I want Dr. Bruns to do it. You may have done the surgery, but I've got this relationship with Dr. Bruns, and I want this to last." So, I mean, it just underscores the fact that it is a team approach, and not only do the patients get better care for that, but it adds, I think, a richness to the practice for both of us to allow that to occur.
Yeah, I remember that patient because at the beginning of her process of her journey, she was very anti anybody but the surgeon doing anything. I remember I had to win her over. I had to, hey, like I'm a pretty smart guy. I know what I'm doing, and trust me, I've done this a couple of times. You're not my first. But if you're listening to this and you don't know the technology, the final lock-in, there's really not a whole lot to it. It's just kind of locking the door. So anybody could really do that part. That was pretty funny. Rick, what about you? I mean, because you guys do a lot of refractive surgery down in Georgia.
We do refractive cataract surgery. We're not doing the LAL yet. We've danced around it. Our mode of practice, we have multiple satellite offices in rural Georgia, and so some of the logistics, we're going to need to come up and visit Vance to see how you do that in the rural areas there. But it is something that I think. What John just said, I don't know if you realized when you said it, how powerful that was when you sung Nick's praises. When the surgeon does that in front of the patient, that is so powerful to this collaborative, this really team approach to eye care. And I have found that is the biggest thing in making this song sing, is that we have to be supportive of each other as well clinically and support each other's decisions and make sure we're both reinforcing the same things with the patients. Be reassuring with them. Be helpful to them. Do our usual excellent level of care. But when the surgeon backs up the optometrist from the get-go, our path is so much clearer, so much easier, and. I mean, I don't know about you, Nick. Now and then I will have a patient who I walk in the room and the first thing I get is, I thought I was seeing the surgeon. And I have to explain, well, you will when I tell you you're ready. I'm going to make sure we are all set, that this table is set, that the road is clear, that your path through the operating room will be as clear as possible. You and the surgeon are going to have a good talk and you're going to agree on your treatment plan, but not until I think you're ready, because I want to make sure that when you come back to me, I've done everything I can do to make it better. But that only works when the surgeon backs me up on that too. And throughout my career, that's been the case. And I think that is a huge part of the success of this model, is that the surgeon that brings a Nick Bruns on board or me or our colleagues on board has to see the skills that we can bring to the table and teach us those we don't have patiently. And when we make a mistake, don't throw us under the bus too fast, but instead teach us how not to make that mistake. Because especially early in our career, we will make judgment errors. As we're learning the whole skill set that we need, and fortunately, we'll continue to learn. There is still so much that I am discovering as I keep going on here. So I think that was just very powerful when you said that, John. So kudos to you.
Well, we learn from each other, and I've learned so much from Vance and from Nick and from yourself, Rick. But I tell you, one of the things that just resonated and has changed, the way I think about things, it was Vance, what you taught us early on, and that is it starts at the front desk, that every patient who walks in is treated like a welcome guest, and they are treated with the not only utmost respect, but brought into what feels like an embracing environment. And some of that is just a kind word saying, "Oh, you're seeing Dr. Thompson. He'll be right with you, and he is so great. Just have a seat." Or when our clinic, when a patient is coming in, and the front desk will say, "Oh, I see you're seeing Dr. Bruns. We've got a 10:10 appointment this morning. You're going to love it. He is so good. And we'll be right with you." I mean, and just that one little statement, which is not forced, it's real and it's true. And just to say that, and Vance, hats off to you. I think you've taught more people how to incorporate a sense of embracing into your practice. And I'd just love to hear you talk a little bit about that, Vance, because I think it's so important.
Well, what we do when someone allows us into their lives is one of the most intimate things a fellow human can do in trusting someone with their eyes. And I think that medicine in general just misses an opportunity to really touch a person's life by just kind of taking care of their problem and not thinking about the experience and the journey that they're putting the patient through. And I became fascinated with this, in the 90s because I was already fascinated with the hospitality industry. I mean, I was a waiter, I was a bartender. I loved the idea of taking good care of people. And I worked in a nursing home and I worked as an aide in a hospital. And when I saw that, the restaurant side was treating people better than the medical side, and then started to see that there was books that I could study that the hospitality industry, utilized. I started thinking about and hiring consultants that, would teach me how do we bring this to the practice of medicine, and it was really probably one of the most impactful things that ever happened in my journey was actually buying the books and studying with my team and choreographing the patient experience, drawing out our whole patient experience cycle and seeing how we could touch their lives. And what I started to realize in that journey of what we call the patient experience is that, wow, the team experience was even more important. I actually started developing a saying that I've made, groups of 5,000 doctors gasp when I say the patient comes second. And obviously, I've taken an oath and I'm going to do the right thing for the patient. But if the team truly feels like culturally they come first, they will create an environment that is so impactful that the patients that walk into that clinic will say, "I don't know exactly what's going on here, but I love how they treat each other. And I love how they treat me. I trust them to do my eye surgery, and I'm going to tell my friends." And so it's become such a powerful journey for us that I've developed this saying in my practice, and I say it over and over, and that is the team that loves and cares for each other will create an environment where the patient feels loved and cared for. And Coach John Wooden, the coach of the UCLA Bruins, was the one who, gave me the guts to use the L word in the workplace. But it's just really had a huge impact on our practice and our practice journey. And I thank you, John, for bringing it up.
Well, and that it's so key. And so as we talk about the collaboration among the professions, which quite frankly are synergistic, they don't just work together, they work better together. And so from the perspective of how our professions are evolving, that has been such a nourishing part of my journey to see how we can provide a team approach. And Vance, you totally have not only embraced that, but you've taught so many people the critical nature of you can't fake happiness. You're there, and if it's organic, you feel it. And from that perspective, that's where I find the value of being able to provide not only great care, but it's fun to go to work. When you have an environment like that, it doesn't create a problem to say, all right, I'm going to get up a little bit earlier or stay a little bit later because I kind of enjoy what I'm doing in a big way.
Culture, that's culture. Culture is so important. And I guess the collaborative model doesn't necessarily just refer to OD and MD. It refers to tech, front desk, coordinator, administrator, everybody. I mean, our team, and I grew up playing sports. I played sports competitively since I was a little kid. The team is just ingrained in me. Nobody can win a football game on their own. It takes 11 guys. Nobody can win a baseball game on their own. It takes 9 guys. You have to have everybody going the same direction. And in this game of ophthalmology, this game of refractive surgery that requires such precision, we do not do a good enough job if there's some one person who doesn't believe and doesn't subscribe to the fundamental pillars of what the practice is. And when you create that culture, when you surround yourself with those people who believe as much as you do, that's fun. Those are fun days. And we have, and John, I'm proud to say that we have a really good group right now where I'm excited to be at work. It hasn't always been that way. Sometimes it does take some reworking of the staff to get the right people. But one thing you can't fix is attitude. You can't fix ambition or attitude, but you can train. You can't. But you can teach other things. I feel like we can teach a lot about eyes. We can train staff and tech support to do certain tasks in the clinic, but you can't teach them to be nice. And you can't teach them to have empathy. Not everybody has that. And so to find those people, that's where it's really, really important and impactful. So with this model and the whole team approach, I think this definitely applies to different subspecialties, but what about, do you find this sort of idea, what we're talking about mainly right now is refractive cataract surgery. Do you think this extends over into retina? Does it extend into the glaucoma world? Other subspecial peds? Does this idea, especially I guess specifically involving optometry, extend into those worlds? What do you guys think?
For sure. I mean, again, I think with the growing patient population and the growing needs, and we're just not training doctors fast enough, I think this is absolutely critical that we continue to grow the collaborative care, model. And so I think it does filter into other specialties. I think refractive surgery and refractive cataract surgery and now glaucoma have set great examples to set the stage for other areas of eye care. But indeed, I think it extends into other areas.
So what we've really seen is how effective we can be in the screening exams that are part of individuals who have medical conditions. So we know that diabetic patients, they have to be screened on a regular basis, and that's just part of the care model that the primary care doctors are judged on. So they have to be seen. But we know that often 5, 7, 10 years into reasonably well controlled diabetes, they don't necessarily have a problem problem that needs to be treated, but needs to be followed to look for problems. Well, that makes so much sense to have that screening. It doesn't have to be done by a retina specialist at all. And in fact, that is something that is completely within the wheelhouse for primary care and for optometry. And I think the same is true for macular degeneration, where we have dry AMD and we screen our patients with OCTs and we have them on a regular basis. We'll watch for potential conversion to wet AMD, but yet these are patients who, one, the refraction is critical because a line of difference can be a huge difference in quality of life, but also making sure that they're not losing ground for something that could be treated. And so the treatment, a medical treatment and following for macular degeneration is another huge aspect of what we do in our practice with the optometric care that is provided. We have 3 optometrists that work in my practice, and they're all just so good at this. And quite frankly, I think we provide better care for having had that team approach.
Mm-hmm.
What about you, Rick?
I think talk about glaucoma as another subspecialty. I'm not anywhere near close to a glaucoma surgeon to do procedures, so we will do some minor MIGS procedures in our facility. But anything beyond that, I have to refer an hour plus away to a glaucoma surgeon. And that has very much become a collaborative effort. I'm friends with these people, and we have learned together. Again, another episode where I had to learn more, where it's just not practical for some of these patients to travel for care. So we will co-manage these patients. I will do the post-operative care after glaucoma surgeries as well. And certainly we can handle and follow glaucoma patients, much like you talked about the macular degeneration patients, with appropriate screening, with OCT, with fields, with refractions, with monitoring the pressure, with continuing the medication massaging of what we need to do to keep them controlled as well as possible in a progressive disease. But much like a cataract surgeon, a refractive surgeon, we want to keep the surgeons doing surgery and keep everybody practicing at their highest skill level, all for the betterment of patient care. And I strongly think optometry is poised to assist in that. And glaucoma is just one example. Cornea surgery. I mean, cornea transplants can be well followed by an optometrist, as well as referred appropriately when it's time for a partial thickness corneal transplant of any type, or a full thickness in certain cases. So I think there's lots of room for expansion of the model for those who choose to, try to be a little more progressive as time goes by. Cataract and refractive surgery is, I think, set the model for others to follow.
So that kind of brings me to my next question. I get this question all the time, both from surgeons and from optometrists. From the optometrist, it's how do I find a surgeon who's looking for somebody to come in and work in their practice as a refractive OD? And from ophthalmologists, it's how do I find an OD who is capable and willing to be that other side, that left hand to my right hand? What I tell them is you can't put a square peg in a round hole. You got to find somebody who's motivated. Vance, you started your practice. I mean, as you built, what qualities were you looking for in your ODs when you brought them on board? What were you looking for?
Well, Rick said the magic phrase, you can't, train kindness. You can't train nice. And, whoever joins my practice, it just starts out with being, a good person. But then after that, a super high standard, good quality training, and someone who's, willing to say, I don't know. I've called John, before with, things that, I just didn't know. I've asked the optometrists that I work with, for their opinion all the time. And so I think, someone who's willing to, when they don't have the answer, or they don't feel like they've totally maybe connected with that particular patient, that we are all, have a higher calling than having to be the one to take the football in for the touchdown every time. It's really about, making sure we're doing the best for that patient together. So I'm looking for good people with good quality training who want to be on a lifelong learning journey. Every day I wake up trying to figure out what I'm going to learn that day to make me better. And I want to work with people that are attracted to that, because if they're not, I can be pretty fatiguing. and so this idea of, enjoying the journey together and growing together, after that, I mean, it's not complicated, to tell you the truth, as long as those criteria are fulfilled.
That makes sense. I mean, I don't think anybody really jumps into this practice modality with the idea of being there for a year or two. I think when you get into this is now your path. This is your career, because it is lifelong learning. And frankly, everything changes after year. We're getting new stuff every year. So this is an active process. John, what about you? Do you have anything to add?
Well, my advice to optometrists who may be listening to this, if you are in your training or finishing up your clinicals and are thinking you want to be more medically oriented, look at doing postgraduate training. Look at doing a residency. There's a self-selection right off the bat for individuals who have that sense of, one, I want to learn more and I want to get better and I want to have more exposure. Also, it also puts you into uh, a, a situation where you get to know people on a more personal basis, and there's recommendations. At the end of the day, eye care is a very small specialty. On the ophthalmology side, we pretty much all know each other, or not more than one, degree of freedom away from each other, and so it becomes more a matter of, hey, I just had this resident that is fantastic, and we have a resident every year, and quite frankly, without fail, they have been. I think I've been told by my staff that they're like kittens. You can't keep them all. They're all so good. You want to hire them all. But by the same token, we can say, all right, look, I have a friend who I know is looking, and we've got somebody who I will stake my reputation that you will like. And so, from a practical standpoint, if you're an optometrist going through your training, doing that, it's not necessary to do the residency if you've got a few years under your belt. But again, sort of do a little self-introspection as to what you want out of your career, and I think that will provide the guidance to take you where you want to be.
That's a good point. And even if you decide not to do extra residency, this is coming from somebody who did not do a residency.
Two of us.
Two of us, both of us didn't do residency, and that's not the right way or the wrong way to do it. I think the two of us I got lucky. I fell into a spot and I was motivated to learn there. That worked out for me. But during your fourth year in optometry school, you're doing rotations and you're doing externships. So you can, on some level, pick where you go. And so maybe don't pick the shiny boutique clinic in Florida. Maybe pick the place that's, for me, it was Saginaw, Michigan. I learned all about cataract and retina in Saginaw, Michigan. It wasn't the sexy spot to go. It was where I wanted to go because I was going to learn. So pick spots that you're going to learn. Rick, what do you think about that?
I agree. And I think getting a residency in today's world is not going to harm anybody, but it's not required either. The base knowledge is there. What you don't have is the clinical experience. So if you don't have a residency, you're going to have the challenge of learning a lot more under a very patient surgeon, hopefully, or a practice that has brought in more than one optometrist and has a method of bringing someone on board, or a practice that uses optometry in more of a primary care type of a role with less medical and surgical involvement, and then maybe you can evolve into that. But I would say to ODs that are already in the workforce that are asking, how do I find this position? One option is to talk to your reps. Pharmaceutical reps know the practices in the area, and that's an option to, is anybody out there, hiring? I would love, or, is there anybody I can meet with? And I think calling somebody, if you have their name, hey, I'd love to buy you a cup of coffee and just talk. And don't do it as a job interview. Do it as an opportunity to meet and greet, and maybe you meet with a John Vukich, and he's not hiring you, but maybe he knows somebody who is looking for an ambitious young OD. So there's ways you can do this, even after 3, 5, 10 years, if that's what your goal is, and you find that itch just hasn't been scratched yet. I think it's much easier now than it used to be. There's more practices with more ODs involved. So I think the opportunities are there. When I did it, it was happenstance. There weren't a lot of ophthalmologists and optometrists that were really in a collaborative setting 40 years ago. It was much less common, much more common now, and thankfully so, for the good of the patients. I think that really goes back to that. The care is going to be much better. But, for ODs interested in this, great. I am all for us working together. I didn't, I made a choice a long time ago. I could have been in private practice. That wasn't for me. I didn't want to be in an optical practice and sell glasses and contacts, mostly because I was a lousy businessman when I was young. I needed to learn that too. So instead, I let somebody else worry about that. And I decided my career was going to be patient care. And then as my career evolved, especially when I moved to Georgia, my career, one of the emphasis for me was doing things to help my colleagues. And we began teaching the optometrist medical eye care and surgical management, so that my colleagues now around me are much more versed in this, and they don't need me as much. And I love that. And I'm proud of you, Nick, for doing the same.
Yeah, that's a big part of our practice, John, is education. We do a symposium once every 8 months or so, and it's a pretty big one. The last one we had about 70 ODs there in Milwaukee, and the collaborative model extends outside of our clinic. Let's go one circle even further. It extends out into the community. And so now we're teaching the community, the ODs that we work with day to day, about all these new things, about new technology, about proper methods and, standards of care. And we're learning from them as well. This is not just John and I standing at a podium. And Rick, you've came and talked with us a couple times too. It's not just us standing at a podium and talking to blank faces. It is an interactive event. And I'm so proud of that, John. I think we've really grown that. And I know the ODs that we work with and the ODs in our community, those are my friends. These are people that I've gotten to know on a very personal level. And everybody looks forward to that. They look forward to that. And it's not because of the content necessarily, as much as it is the collaborative environment. The fact that John Vukich, with all of your experience and all of your accolades, you are there to learn too. And that's awesome. I think it's humbling from an OD perspective. That's super, super humbling. And I'm real proud of that.
Well, thank you, Nick. Those are kind words, and quite frankly, we're having fun as we do this. Nick, I think we've covered a lot of ground here, and I thank you for taking the lead with the education that you're doing through Peer-to-Peer Academy, which is a new foundation that you have started to foster education and to bring innovative ideas into optometry and ophthalmology, which I think it just shows not only initiative, but it shows how committed you are to education and to providing a better path forward for our profession. It's really nourishing to be able to say we're not just leaving a trail of pseudo-fakes or refractive surgeries behind us. We are shaping our profession in a meaningful way. And hats off to everyone in this talk or this meeting tonight, this podcast, because it is something that we learn from each other, and it's just so much fun to be a part of.
Well, one of the pillars of Peer-to-Peer Academy is collaborative networking. It's a small world. You said it right. It is a very small world. And I'm realizing that every single year, just how small the optometry and ophthalmology world is. And so the idea is that it's to make the Vance Thompsons, it's to make the John Vukiches, to make the Rick Van De Veldes accessible. It's to connect people with experience to those who are early on in their training or early on in their careers, and to share knowledge with each other. So guys, I think we're coming up on time. I appreciate everything. Thank you for all of your insights. This was an awesome discussion. So thank you all again for joining for episode 2. We'll talk to you later.
Thanks everyone. Bye-bye now.
Good night.
Thanks to our sponsors RxSight, Star Surgical, and Lensar. Because of their support, we're able to bring educational content and discussions like this to you.